Hello and welcome. My name is Richard Taverner and I'm your host of Any Further Questions. You are listening to a special episode of the podcast where we are sitting down with the three speakers who gave lectures as a series called New Hope in Cancer, which was in partnership with Novartis. So we thank them for sponsoring and supporting this series. All previous episodes of Any Further Questions are all available to listen to on Spotify and Apple Podcasts, so please do and check them out now. My guest today is Professor James Larkin. James is a medical oncologist specialising in the treatment of melanoma and cancers of the kidney. His research interests involve trying to understand cancer and its consequences better, as well as developing improved treatments, particularly with targeted therapies and immunotherapies. Earlier this year, James gave a lecture with the title Immunotherapy, Cure for Metastatic Cancers. It is available to watch on our YouTube channel, and so for context, it's probably a good idea to go and watch that before listening to us. James, welcome. How are you?
I'm good, thanks.
Firstly, what is immunotherapy and how does it differ from chemotherapy?
The idea of immunotherapy is to harness the immune system to treat a disease. So I guess that our context here is cancer, but in principle, actually immunotherapy can be used to treat various other diseases in humans. So you're really trying to use the body's own defences, if you like, to try and treat the cancer. And one of the reasons we think cancers grow is because the immune system is not recognising them, allowing them to become large enough to see or to feel. The term chemotherapy, again, one needs to be a bit careful, I think, about exact definitions, but in cancer we'll often use the term chemotherapy to mean what we call cytotoxic chemotherapy. So that tends to be traditional chemotherapy drugs which have really been around since the 1940s and 1950s. There's lots of different chemotherapy drugs, but I guess, when I talk to patients about this and when we're talking about side effects, I'll say things like, well, we're using immunotherapy. It has completely different side effects from chemotherapy. With chemotherapy, I think most people would know that you can get things like hair loss and tiredness and nausea and vomiting. And each has its place would be the other thing that I would say. Some types of cancers, particularly notably hematological cancers, leukemia, lymphoma, actually chemotherapy is a really good treatment for that, and several different types of solid tumours, ovarian cancer would be an example. Whereas immunotherapy, again, it doesn't work for every type of cancer, but certain cancers are particularly sensitive. So that's a quick, maybe top-line summary.
And what are metastatic cancers?
Yeah, metastatic means spread.
Okay.
I can never remember if it's from Latin or Greek as a consequence of my deficient educational background. But if you have a cancer at a primary site and then it spreads to other parts of the body, that would then be called metastatic by definition. There's a little bit of nuance there. So, for example, stage 3 cancers normally involve nearby lymph nodes. Stage 4 means spread around the body, and in principle, metastatic could describe both of those scenarios.
Let's get to the first of our questions we had online. In which stage is the best time to use immunotherapy?
Excellent question. I'm not sure we really know the answer to that at the moment. What I would say about developing drugs to treat cancers is that initially they're tested in cancers that have spread, sometimes in the very early stages in cancers that have spread and exhausted all conventional treatment options. And then the further along you go and the more the drugs are tested, they then get into the earlier stages. So we know at the moment, for example, with immune checkpoint inhibitors, a type of immunotherapy, we can certainly see benefit in several different stage 4 metastatic cancers, melanoma, kidney cancer, lung cancer, so on. After that testing and often approval of drugs in that setting, we, I guess, as a community then start asking the question, well, actually, if you use the treatment earlier on, say, for example, after someone's had surgery to remove lymph nodes involved with cancer, might the treatment work in that situation? And we now know, certainly I treat melanoma and kidney cancer, in earlier stages of melanoma, immunotherapy can also have benefit to reduce the chances of the cancer coming back. So that's called adjuvant treatment, Is there a best time to use these drugs, which is really the question? I'm not sure I could really answer that very easily. One thing I would say, though, that if you're going to use an immunotherapy treatment, you want the immune system of the person to be working as well as possible. And sometimes, particularly with later stage cancers, by virtue of the burden of the cancer and involvement of lots of different organs, the immune system may not be working quite so well as a consequence of that. So there are, I suppose, sweet spots there. Maybe a final point to make, which I think is relevant, is that if you are treating earlier stage cancers after potentially curative surgery with the aim of stopping the cancer coming back, we actually don't know in that situation who's got a cancer that's destined to come back and who hasn't. So that concept, adjuvant treatment, by definition, will involve over-treatment, because you're going to be treating some people where actually the cancer's not destined to come back. So there's a bit of nuance there.
Do all immunocheckpoints do the same function?
Answer to that is no. Immune checkpoints are molecules on the surfaces of cells, immune cells and other cells, and the function of them in health is to regulate immune responses. In other words, if you, let's say, have an immune response to an infection with a virus or a bacteria or something like that, obviously you need to have the immune response, but also you need to limit the immune response afterwards. And that's one of the areas in which immune checkpoints come in the context, for example, of fighting infection. There's lots and lots of different immune checkpoints that have been described. They all have different functions, and in a way, one way to think about it is that they're the things that allow immune cells to talk to each other and talk to other cells in the body, and those interactions are actually very complicated. And I think it's fair to say, although we do know a fair amount about that, there's probably a lot we still don't know about that as well.
What is the solution of immunotherapy that causes side effects such as cardiotoxicity?
Well, immunotherapy with immune checkpoint inhibitors can cause side effects, but all drugs, not just anti-cancer drugs, cause side effects. And I think the most relevant point there, certainly if you're sitting with a patient, you're talking about treatment, would be, what's the potential benefit of this treatment? Is this a potentially curative treatment, or is this a palliative treatment? And then what are the risks of treatment? And a major component of the risks of treatment is side effects. All drugs are tested very carefully early on to try and make sure that the dose is correct and so on and so forth. And actually, at the end of the day, when drugs become available for routine use, this whole question of benefit and risk has actually been quite carefully worked out, shall we say. So it'd be wrong to say that there aren't side effects with immune checkpoint inhibitors. And for me, very much the question is talking to patients about the risk of side effects, making sure that they understand what they should do if they develop side effects. Actually, in practice, the most important thing of all, I would argue, is that patients get in touch with you really quickly if they do develop side effects, because typically if you catch side effects relatively early, they're much easier to manage than if someone's had a side effect like diarrhea or something like that and they've been at home for a week or so. And the subject of how you manage side effects is kind of a big subject in its own right, but all I would say is that the main treatment that we use for a lot of side effects is drugs to dampen down the immune system, particularly corticosteroids, but there are other drugs we use as well.
Sticking on side effects, regarding myocarditis as a side effect, how do we treat patients with checkpoint inhibitors with underlying heart disease?
Yeah, there's two questions in there. So myocarditis, inflammation of the heart muscle, is a rare side effect of immune checkpoint inhibitors. You're talking about sort of around the 1% type of level. It's increasingly well recognised. And again, if you have a suspicion of that, picking up early definitely makes treatment much more effective. Typically, again, we would use steroids to manage myocarditis, and typically that treatment is successful. So in my head, I suppose myocarditis is one of the rarer side effects that we sometimes see. Yes, it can be serious sometimes, but again, it's generally a manageable side effect. The second part of the question is about people with underlying heart problems, and underlying heart problems is a broad term because there's lots of different underlying heart problems that you could have in principle. I think the reality is, certainly in developed countries, by far the biggest underlying heart problem is hypertension and coronary artery disease. And, I don't know what percentage of the population over 60 are on drugs for high blood pressure, but it's a substantial proportion. But the take-home message here for me is that people who've got underlying, let's say, hypertension or ischemic heart disease, from what we know and what we've seen so far, that doesn't seem to alter the risk of getting an immune side effect like myocarditis. So, I saw someone in clinic this morning actually where this potentially came up, and of course you would note it as part of your assessment and discussion with the patient, but it doesn't seem to increase the risk of side effects.
Now, immunology would be fantastic if we could get it to be really effective for rarer cancers and treating rarer cancers. And this question is, what's the role of immunology in rarer cancers where recruiting enough patients with the same disease is hard for prospective studies?
Yeah, I don't think the issues for rare cancers are any different from immunotherapy to targeted therapy or any other particular type of treatment. The problem is that it's difficult to do large trials by definition because the patients just aren't out there. So there's maybe a couple of points here. With immune checkpoint inhibitors, they've been around for 10 or 15 years now, and I get asked this quite a lot in clinic, and actually they have been tested in lots of rare types of cancer. I'll give you an example, which I treat, adrenocortical cancer, which is a cancer of the adrenal gland. It's actually very rare. And quite often patients with adrenocortical cancer will ask me, can immunotherapy work? And I can say to them, well, actually, during the course of the development of these drugs, they have been tested in adrenocortical cancer, and it doesn't really seem like there's any particular benefit there. So that's one part of the answer. And then the other part of the answer is sort of, how do you do clinical trials? Well, the gold standard in oncology, and I think in many areas of medicine, is to do randomized trials of new treatments where half the people, let's say, in the trial get the established standard best treatment available at the moment, and then the other half might get the new treatment. And from a statistical perspective, doing randomized trials requires adequate numbers of patients to go into the trial so that they can be done in a reasonably timely fashion. And with rare cancers, that might not be possible. There might not just be enough people there, but you can do non-randomized trials. In other words, take a group of people, 20, 25, however or more, and then look in that group of people to see if your treatment of interest, your new treatment, seems to have any benefit or not. It's not as good, obviously, as doing a randomised trial because you kind of don't have an idea of what would have happened otherwise, but there are ways around this problem. And from the perspective of regulators, and this is important, in other words, the people that determine whether a new medicine's going to be available or not, in my kind of experience, regulators are sympathetic to the fact that you have this problem with rare cancers, and actually it's true for any rare disease. You need to have a way of working around that, and there are ways of working around that.
I just thought of a question myself, actually, so I'll chip in. What's the minimal amount of people that's sort of needed for a randomised trial? What's the acceptable number that you would?
It's a statistical question.
Okay.
So typically, in oncology, a phase 3 trial, which is a randomised trial, would have anywhere, let's say, a minimum between 500 and 1,000 people in it overall. And generally that's acceptable for statistically working out if a new treatment's better than an existing one and getting an idea of side effects. That's an important part of this as well. But you can do smaller randomised trials, and sometimes you will see randomised trials with maybe only 100 or something people in them. Usually those are called randomised phase 2 trials. That's a sort of technical distinction, I suppose. And the idea with smaller randomised trials is they aren't necessarily about formally establishing the benefit or otherwise of a new treatment. They're actually about trying to get a sense of whether a new treatment might potentially be of benefit as a prelude, numbers allowing, to then going on to a bigger, more definitive randomised trial.
It's a lot more robust than, let's say, L'Oreal on an advert saying that 73% of women of 16 women agree, or something like that. I would imagine so. Yeah.
Oh, there's all sorts of levels of evidence, yeah. and having a randomised trial is a pretty high level of evidence.
Yeah.
But I wouldn't be completely dismissive about other types of evidence. I mean, sometimes it's just not possible to do randomised trials, and I think the in clinic with patients, you actually have to try and interpret the data, whatever they are, randomised trials or not, in a way that is helpful to the patient. And sometimes we just don't have randomised trials. Rare cancer, a good example.
You mentioned earlier about adjuvant and neoadjuvant therapy. Can you talk a bit about that? And we had a question, what is the difference between treatment combination and adjuvant therapy?
Yeah, so just to maybe recap adjuvant first of all. So the idea with an adjuvant treatment is you give it after the definitive treatment, which has been done with curative intent. So the sort of the easiest way to think about this might be for someone who's had an operation to remove a cancer. We know that after that, in some people at least, there's a significant risk of the cancer coming back. And then the idea with an adjuvant treatment, and actually it could be a drug treatment, could be radiotherapy as well, actually, is that you give that treatment afterwards to reduce the risk of the cancer coming back. So that's adjuvant treatment. It's extremely well established and has been for decades in breast cancer and bowel cancer in particular, and for example in melanoma, kidney cancer, the diseases that I treat. Over the last 5 years or so, we now have evidence that adjuvant treatment after surgery is a benefit, particularly with checkpoint inhibitors. Neoadjuvant treatment means actually giving at least some of the treatment before the surgery has happened. And there's been a lot of interest in this in melanoma in particular over the last few years. And we now actually have a couple of randomized trials showing that for stage 3 melanoma, and what that means is melanoma in the lymph nodes where you can actually feel the lymph nodes. If you start the drug treatment before surgery, usually a month or two before surgery, then do the operation, then carry on the treatment afterwards, it reduces the chance of the cancer coming back significantly in comparison with the kind of standard adjuvant treatment. So it's a really interesting area, and actually there are data in several different types of cancer. So I think, in that group of patients, and this isn't every patient in the clinic, bear in mind we're talking about in melanoma palpable stage 3, without a shadow of a doubt, that's very much a major direction of travel for the future.
What are your thoughts on targeting difficult to penetrate tissues, either due to their shielding from immunotherapy or difficulties of delivering treatment?
So if an area of the body is described as being difficult to reach for some reason, then the first thing I would say was, what's the evidence for that? With immunotherapy, for example, the cells that do the work are immune cells, and so immune cells are constantly cycling around our entire bodies, all the time. And to pick out one example, historically there'd always been concerns about spread of cancer to the brain in melanoma, and that it was people call it a sanctuary site, and that immunotherapy treatments may not work in the brain. That's not the case. They absolutely do work in the brain. So first of all, I would say, well, what's the evidence actually that area of the body really is a sanctuary site or difficult to reach? I'd want to see that. Then the next question would be, if it is a sanctuary site or difficult to reach, how do we understand that? Why is it difficult? What's the biology? So that requires research. So I think there isn't a one-size-fits-all here. It's all about understanding why something's happening, and if you can understand it scientifically, then that gives the ability to develop treatments to mitigate the problem.
Which of the new treatments are likely to be the most cost-effective, in your opinion?
The definition of cost-effective is the benefit of a treatment, the effectiveness of the treatment, divided by the cost.
Okay.
The effectiveness of treatments we've already discussed is determined generally in randomised trials, and so anyone can go and look it up. Yeah. This is the upside of treatment. The cost of treatment is not as easy to define for all sorts of different reasons. So sometimes, for example, negotiations between industry, pharma, and payers, and I use the term payers generically. So in this country, for example, the NHS is a payer. Other countries have different health systems. So it then depends, obviously, the bottom part of the equation on the cost. And so unless you actually know what the cost is, you can't really define cost effectiveness. So there isn't a one-size-fits-all answer there, I'm afraid, either.
No, don't worry. Is there anything different about patients who respond to treatment versus those who don't? And I think I would imagine the questioner wants something a bit more than just age and the health of the patient beforehand.
Yeah, age probably isn't relevant.
Okay.
So if we take melanoma again as an example, and we talk about immune checkpoint inhibitors, we do have some factors which, to be blunt, are relatively old-fashioned factors. Age isn't really one of them, like I say, but how well the patients are, how symptomatic they are, is relevant. It's a real truism in solid tumour oncology that the people who've got the least amount of symptoms from the cancer have the highest chance of treatment working in general. In melanoma, there are a few other factors. To some extent, the burden of the cancer, which you could measure on scans by adding up all the different abnormalities, is relevant, but then that also factors into symptoms for reasons that you can probably imagine. We use a very old-fashioned blood test called LDH, lactate dehydrogenase. It's been around for decades, which is also a prognostic factor. And from a molecular scientific point of view, there's quite a few factors that we know are associated, and I stress the word associated, with benefit or lack of benefit from treatment, but we don't really have anything, honestly, that we can use in clinic to say, well, actually, look, the chance of this treatment working is negligible, it's so low we shouldn't even think about it, or we're going to give you this treatment because we've selected you for this treatment as a consequence of X, Y, or Z molecular factors. So for immune checkpoint inhibitors across cancer, there are some factors. PD-L1 expression in some cancers is one of those. But actually, despite a lot of work in the last 5 or 10 years, again, there's probably more we don't know about this than we do know about this.
So I would have assumed wrongly that a fit, healthy 20-year-old wouldn't necessarily be able to fight it better than someone much older, a geriatric.
The key words there are fit and healthy, not
the age.
No, I mean, you get lots of people actually in their 80s,
right,
sometimes in their 90s,
right,
who are really fit and healthy.
Okay.
And I've certainly treated lots of people over the years in their 80s who are fit and healthy. And I would take a view that if you don't, treat them properly, then you're being ageist. And
so a younger body doesn't necessarily fight a cancer better than an older body?
Not necessarily.
Okay.
I mean, I think that the thing about age actually is that you generally have more physiological reserve.
Right.
In other words, you can kind of get beaten up more by treatments and still come out the other end. And kids are the best example of that.
Yeah.
And so the older we all get, the less we are able to withstand side effects, and that's just a consequence of the aging process. But unless you've got real concerns, it would be dangerous to give a particular treatment. Age doesn't factor in. Actually, other medical conditions are sometimes more relevant, comorbidities in the jargon. So that's actually more relevant than age, I'd say.
I think that probably comes from moving away from oncology. I used to be a smoker, and I smoked from the age of 17, 18 until my mid-20s, and then I completely gave up. And I've always been told that by giving up, the earlier you give up, the better your body has a chance of recovering from that, of the damage that you've done to the lungs. So that was probably where the logic came from, was the fact that my body being young can sort of rejuvenate itself. And again, I mean, I'm not sure it's specialised medical knowledge, but as you say, the younger you are, the better you're going to kind of bounce back from anything, including, I guess, the insult from smoking, which is which is a poison basically, or a collection of poisons. Yeah. We had some more questions. How is this all going to be afforded when healthcare budgets worldwide are so stretched?
Yeah, we talked about that a bit under the heading of cost and benefit. And at the end of the day, if you live in a country where there's a publicly funded health service from central taxation, there's lots of different things that we could spend our money on if you think about it just very broadly. And I would want that process to be as fair and transparent and democratic as possible. And in this country, I have NICE, National Institute of Health and Clinical Excellence, who take into account the benefit of the treatment, as we've discussed. They discuss with the manufacturers the cost of the treatment, and then they try to come to a position at least where they make decisions about whether any particular treatment is a worthwhile use of taxpayers' money effectively. So that's how I see it. New drugs are expensive to develop. I think everybody knows that. And so pharma companies spend a lot of time developing drugs, hundreds of millions, billions of dollars, which actually don't make it in the end to market. Obviously, pharma companies do make pretty large profits as well. So that, there's a balance there. And then the other issue is probably patent life. It's worth mentioning here as well. So drugs have a patent life during which the manufacturer is able to charge effectively as they see fit, but they obviously need to get it reimbursed and paid for as well. Yeah. And then after the patent life, then actually in principle anybody could make that drug. So in terms of, if you like, the rest of human history, other things being equal, all these drugs that have only been around for 5 or 10 years in due course will become much cheaper, I'm sure.
Should cancer care be delivered differently, and what would it look like if they were able to design it?
Cancer care is getting increasingly specialised, but you maybe make that argument about many diseases. Even in the last 20 years since I've been doing it, actually knowing how to manage a particular type of cancer and the treatments has become relatively complex. So those are arguments, obviously, for specialisation. But on the other hand, I think you need to temper that with access for patients as well. I mean, so what's the balance there? And if you look at the way cancer care is organised in this country, there are some cancers, so haematological cancers, children's cancer, sarcoma, that are centralised and effectively regulated as a consequence of the fact that they're relatively rare. Should that be happening for commoner cancers? I'm not so sure about that. If you live somewhere that's relatively geographically isolated, I don't think it's unreasonable to expect to see someone relatively close to your home who has expertise. I think the other bit, and I hope this isn't trite, would be that these days actually communicating electronically with other people around the country or around the world is actually relatively easy. And so, for example, in the old days, kind of pre-COVID actually, we would have these weekly multidisciplinary meetings, and we'd all sit in a room, and radiologists would put the scans up on the screen and all that sort of stuff. We'd sit around and we'd talk, and we struggled actually, maybe this is just a generic NHS issue, we struggled to sort of digitise it, if you like, and put the meeting online. And then COVID happened. Now, what's that, 24? So it was 20, wasn't it, 4 years ago? And then overnight, we went to a situation where our meetings became virtual, our case discussion meetings, and now they've stayed virtual. And so in principle, anyone can dial in from anywhere. And to the point, we will sometimes have colleagues from other parts of the country dealing with relatively rare problems, say a rare type of melanoma, and then they dial into our meeting, and then we talk about the case. And so, for me, it's a sort of a democratic type of question. What's the right balance where you can get the level of specialisation required to have good quality care, but at the same time you have accessibility? And again, I'm not sure there's going to be a one size fits all.
Are strategies borrowed from other countries and other healthcare systems, and is information shared in that way, or is it just kept in Great Britain?
I think that depends a lot on context. So research information is shared globally. I think clinical information less so, and I suppose the argument there would be that in terms of clinical information, it's shared around, let's say, the National Health Service, although there's various kind of impediments to that. What would be the argument for clinical information within the NHS being shared more widely around the world? I think I would only really see that as potentially being useful in a research context, at least off the top of my head, which then sort of brings us a little bit into AI and data mining, which of course, is very exciting.
which can be our next question. So AI comes up a lot on this podcast. It's a question asked by lots of people, and it's a question here, so I can put it to you, James. Can or has artificial intelligence helped the advancement of immunotherapy?
Not necessarily that I'm aware so far. I suppose a little bit depends how you define artificial intelligence. But as I think about artificial intelligence, I'm not aware that it has. I'm sure it will, just like every other area of life. It's just a question of when.
Or how, possibly, as well.
And maybe how,
Yeah.
and also what it looks like. So again, when you get back to data sharing, there's various hurdles there, all sorts of different types. Some of them are legal, data protection, that kind of thing, which is all legitimate. So I think a lot of effort at the moment, and it's not my area of expertise, is going into working out how to navigate those hurdles with the appropriate protection for people's data. But I think the potential is incredible, being able to examine these really large data sets in a dispassionate way or an agnostic way, or however you want to describe it, to look for patterns that the human eye, if you want to call it that, may have missed. So as far as I can understand, the technology already exists to do this, and I suppose over the coming years it's going to be a question of implementation and to some extent regulation as well, I think.
Our last question: how can the system from big pharma through to patient manage personalised medicine, which is clearly becoming a thing?
Yeah, I mean, we're already seeing personalised medicine. And again, I don't think it just applies to cancer. I think it's a much broader question. And some of this is also going to come back, I think, to these very large data sets at a population level. How are they going to be analysed? How are they going to be collected? Are the appropriate safeguards in place? So, I mean, I think we're already there with personalised medicine, but to some extent, I think it's almost as if we've had baby steps so far. And I think actually, if you think about it, there's vast potential for doing this. It has to be collaborative, but again, that then gets back to the hurdles, the legal and the data protection and all those other sorts of things. So I'm sort of relatively optimistic. I mean, I'm intrinsically impatient, actually, so I'd kind of like it to have happened already, and it hasn't. But I think that speaks to the complexity of the problem and all the different parties involved in the discussions. I think we'll get there, barring disasters, but I'm not sure quite when.
Good. Well, there's optimism there. That's good. If you haven't already watched James's lecture, then please do go to our YouTube channel to watch it. It's a really fascinating watch and it's encouraging. Thank you very much for joining me today, James, and thank you at home for listening. James's lecture was one in a series of 3 on cancer. The other 2 are also available to watch on our YouTube channel. They are called The AI Revolution in Cancer Imaging by Dr. Richard Sidebottom and How Cancer Genomics is Transforming Cancer Care by Professor Sanjay Popat. James, thank you again.
Not at all, thank you.